Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
You know, when you hear the word transplant, you immediately think about an organ like the heart or the liver or the kidney or even a lung. But transplant surgery is actually now possible in exciting new areas, including the hands and even, well, the face. The goal of face transplant is to restore normal anatomy and improve function as much as possible for patients who have facial injuries as a result of burns, trauma, gunshots, or some congenital abnormality, something they're born with.
Mayo Clinic recently performed a face transplant, removing a great portion of a donor's face and attaching it onto a patient who had previously suffered a devastating facial injury. Here to share the story are the surgical director of the Mayo Clinic Essam and Dalal Obaid Center for Reconstructive Transplant Surgery, Dr. Samir Mardini, and the medical director for the program, Dr. Hatem Amer. Welcome both of you to the program. It's an amazing story. We're so anxious to hear more about it.
Dr. Amer, Dr. Mardini, both of you, welcome to the program. Since this, I think, was your first one, we want to hear the story. Who's going to tell it?
Well, there's a lot to tell. Thank you so much for allowing us to be here to join you on this. The face transplantation is a reality. It's a clinical reality. It's here. It seems to be here to stay. There's been about 37, 38 done around the world. And it's producing great results in patients that need it.
This is the first one at Mayo Clinic, though?
This is the first one at Mayo Clinic.
Okay.
Our patient's motivation for undergoing this procedure is mostly for function. Our patient didn't have teeth. He wasn't able to chew. He was having a really hard time in restaurants or with people where he had to spend more than an hour trying to dissolve the bite by sucking on it for a while. This was a major issue for him. He had issues with breathing. He didn't have any areas open for breathing through his nose. And he wanted to swim. He was at risk for aspirating, for having water going to his lungs when he swam, and that was a big motivation for him. And of course, aesthetically, it's a huge deal for these patients because they're going into an elevator with a mother and her child, and the child is looking again, and then asking his mother what he's looking at. Mom, what's wrong with this patient? So with this procedure of face transplantation, we're not reconstructing, we're actually restoring. You're taking someone with a severely deformed face and you're actually bringing them back to normal, as close to normal as humanly possible. I met with our patient, we were together with the patient, Dr. Amer and I, a few days ago, and he's such a wonderful guy. We like talking to him, and we were just asking him how he's feeling and how he's doing. And his responses are, from the aesthetical standpoint, he says, I'm completely blown away. Every time I pass by the mirror, I can't believe what I'm seeing. I never thought in my life that I would be able to see my face again like this. It's very touching. And when he was in an elevator with a child just recently, he said the child looked at him and looked away, and they kept on going like nothing ever happened. It gave him chills.
Is he someone who was injured?
So our patient is a wonderful gentleman that I met 10 years ago when I first came to Mayo Clinic. He came in as a trauma victim, and he suffered a injury to his face. And at the time, we ended up restoring mandible with vascular.
That's the jaw.
The jaw. We used fibula from the bones
small
of the
bone
leg,
of the leg.
small bone of the leg with the vessels, reconnected that, created his jaw, his lower jaw, and then we ended up using another vascularized bone to restore his maxilla, his upper jaw.
Vascularized bone meaning the bone with its blood supply.
With its blood supply,
Better chance of healing.
Operations, better chance of healings. A better chance of incorporating into his normal form, but he still had a severely deformed face. And he was doing well. He's a wonderful guy who went back and started working again and incorporated back into life. And I kept on seeing him maybe once a year, once every other year.
For 10 years, you said?
For 10 years. And over about 4.5, 5 years ago, we were starting to look at face transplantation and seeing that if that's something that we want to do here at Mayo Clinic. And at that time, we were visiting, our whole team, including Dr. Amer, we were visiting other centers around the world that have done face transplantation to learn about the intricate details of the procedures, the issues that are involved in face transplantation. What are the things that the patients, what are the issues that they go through? And we had the fortune of making good friends with many of the surgeons around the world, and we've met some of the patients as well. So we brought that up to to our patient and just said, look, this is something that we're looking at. You might want to look at it. You might want to Google and try to learn as much as you can about it. We're not saying that this is the procedure for you. We're not offering it to you at this point, but I want you to have time to look at this and study it with us, and maybe one day we'll consider this procedure for you.
Well, who's done the most? Where did you go? Where did you visit?
So the procedure was first done in France, and there are two teams there that have done. One team had done 7 of them, Dr. Lentieri's team, and then the other has done 3, and that's Dr. Duvauchel and Dubernard's team.
So, Dr. Amer, what's your role in this? Do you have to give your blessing for this, or you went around and looked and you said, yeah, but I think it's a reasonable idea? Because it's tough to hold a surgeon down sometimes, but yeah, you gave your blessing to this whole project.
I think we're very fortunate because we do actually have very thoughtful surgeons. They didn't want to just go ahead and do it. They wanted to do it for the right patient after they have enough information and whether or not it will benefit this particular patient. So by training, I'm a transplant nephrologist, and that's my profession most of the time. I take care of transplant recipients, mainly kidney and pancreas recipients, both before, during, and after the surgery. So my role with reconstructive transplantation is to evaluate potential candidates from a medical perspective to better understand how they will be able to tolerate the immune suppression and how to match them with prospective donors from an immunological perspective.
When you say immune suppression, you're talking about the drugs to keep the body from rejecting the transplant.
Correct. At this time, anyone who receives a allograft, which is a tissue graft, whether it's an organ or tissue such as a face or an upper extremity, if it comes from a person other than an identical twin, they have to have their immune system suppressed using anti-rejection medications to allow them to keep the organ and not to reject it.
And even if it's not an organ, even if it's a face, you have to do it.
Correct. And we consider face and hands as organs at this time.
And we're a wonderful point in medicine where a kidney transplant is almost just like a daily occurrence and nobody even really bats an eye at it anymore, which is wonderful that we've gotten to that stage. But this is a completely different game. I mean, there's so much more, I would imagine there's so much more emotional aspect that goes along with this.
Correct. At this time, composite transplantation, which is for the most part entails upper extremities, hand or face, is not a routine procedure. It's only to be performed in very well-equipped centers for very well-selected individuals who may benefit from it. And in regards to a face transplantation, for example, we have to weigh the risks of the immune suppression that the person is going to be subjected to the benefit that they would gain from the procedure. So our surgical colleagues identify what could be done using conventional therapies. How can they restore the individual to the near normal function and aesthetic presentation using conventional procedures first. And if they don't find that that is going to be sufficient for a particular individual, then the transplant physicians, including myself, will evaluate them for the risks of the immune suppression and then follow them post-transplant, during and post-transplant. At this point, it certainly is not a routine procedure. It is a very complex surgical procedure, as I've witnessed having attended with the surgeons in their ORs, they were doing it. And the management of these patients post-transplant is also, at this point, still quite intricate. The skin rejects more commonly than any other organ. We have been fortunate that since 1998, with the current immune suppression has allowed these organ transplants to proceed. But still, the long-term outcomes require careful monitoring. Any complications that occur from immune suppression have to be identified as soon as they occur, and interventions undertaken to try and gain the benefit of the procedure and mitigate the risks as much as possible.
Dr. Mardini, you said that you advise the patient. We think that this might work in your case. Start researching it. How long did he consider becoming a recipient of this facial transplant?
So you asked also about the the surgeon's enthusiasm for performing the procedure, and as Doctor mentioned, we have a very thoughtful team here that includes transplant nephrologist, transplant psychiatrist, a social worker, and many other and coordinators and other team members that have a heavy say in what ends up happening with the patient. So that's really critical to success of what we do here at Mayo Clinic, the multidisciplinary approach of things. The patients have to be. There are not so many patients that are candidate for face transplantation. I mean, there are many patients with anatomic defects that could be reconstructed with conventional techniques. That's the most common and will always be the most common. It's the patients that have anatomic defects that we know will require many procedures to reconstruct and will still end up with a very suboptimal result. With a result that, maybe we know that after 15 procedures, the patient will still have a significant deformity, will still have a significant lack of optimal function. And in those patients, we may consider them for face transplantation. It's beyond that. The next step is if we have a patient who we think is a good patient from an anatomic standpoint that would improve from the surgery functionally as well as aesthetically, then we would see if this patient is willing and can truly give informed consent. Can this patient really understand the risks versus the benefits? Because this is a huge thing for us. None of us want to put someone through a procedure that they don't fully understand. We don't know with 38 procedures done around the world, nobody knows all the answers. So the patients have to be aware of that as well. So that's an important thing. And then lastly, the team has to be willing to embark on this adventure with the patient. There's a lot of things that we don't know and a lot of issues that we know we will run into. And we want to have a patient, not just the surgeon, but we as a team all want to have a patient that we are able to work with throughout this journey.
When it comes to face transplants, there's actually a learning curve, and I can understand why only 38 done in the world. We're talking about face transplants, and the first one the Mayo Clinic has done with Dr. Samir Mardini and Dr. Hatem Amer. Time for a short break. When we come back, we'll talk more about the actual procedure.
You're listening to Mayo Clinic Radio on the Mayo Clinic News Network.
Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
We're talking about face transplant, and the first one that has been done at the Mayo Clinic in Rochester, Minnesota. Our guests are Dr. Samir Mardini, plastic surgeon, and Dr. Hatem Amer, who is medical director of the Center for Reconstructive Transplant Surgery. Did I get that all right? Okay, so before we talk about the procedure itself with Dr. Mardini, tell us a little bit more about the evaluation of the patient.
So the medical side comes into play. We have a structured evaluation process which consists of two phases. The first phase is when a person is referred to us by one of our surgical colleagues that they may be a candidate for face transplant or upper extremity, for example. They come in, we assess their medical history, go through any past surgical procedures, any chronic medical conditions. We run a battery of tests to give us some baseline idea of their kidney function, heart function, their immunological situation. They visit with social work, psychiatry, and then we come up with a set of questions that we need addressed, for example, or a certain set of questions that the patient wants addressed. Regardless of the outcome of that phase, if the patient still wants to proceed with the evaluation, we insist that they wait a minimum of 3 months before they see us again.
Got to think it over.
Correct. It's a cooling off
Make sure
period.
they want to do it.
A lot of information is given during that first phase. They have to have time to absorb it, connect with other individuals, learn what the options are. And then the second phase, they'll come back for an ongoing evaluation to follow through with some of the findings that were found during the first evaluation, and then address some other questions that come up at that point. Throughout the phases, the individuals are asked, what are they doing right now? What are they capable of doing? What they feel their life is limited by? What they think the transplant will accomplish? And what do they think may go wrong in the future? And how will they tackle that if the worst does occur?
And what would be the worst?
The worst would be a complete rejection of the organ and loss of the transplant.
And then they would be back to what they were like before, or worse, somewhat potentially worse?
Potentially worse. It depends on what the injury was, and it depends on what was transplanted.
So, Dr. Mardini, from your standpoint, was this done purely for cosmetic reasons, or did you hope for the patient to regain some function, and if so, what function?
First and foremost is function, and that's what the patient cared about a lot. Issues related to the patient had no teeth, so he was not able to chew. His eating took more than an hour. He has to break up the food in his hands, put it in his mouth, lick it for suck on the food for a while before he's able to swallow it. So that was a major concern for the patient.
So you were going to give him new teeth.
We were going to give
part
with
of
the
the
transplant.
Wow.
We transfer the entire lower face, including the jaw, the upper and lower jaw, with the teeth, all in one procedure. So the cheeks, the teeth, the nose, all these structures are transferred in one procedure, and we're able to restore the patient's face. Not
From the eyes down,
From
including the chin.
Our patient has issues with his eyelids that are still reconstructable. So those we're working on with conventional techniques. And because the eyelids are so delicate, unless there's a major reason to put the transplant eyelid on there, we would avoid doing that. So our patient's restoration was from the nose down below the eyelids, and below the chin.
How long does that surgery take?
Were you in there alone? Did you do this by yourself, or did you have a little help?
Not. Absolutely not. This is a team effort. It's a major endeavor. It's a procedure that took us over 50 hours.
50?
50 hours to proceed.
Straight?
Straight. So we have two operating rooms going at the same time. We're procuring the organ, the face. At the same time, we're preparing the recipient to take the face, because our recipient has, like we talked about earlier, has the jaws that are reconstructed, other soft tissues that are reconstructed. So all of that has to be removed in order to in order to fit in the transplanted organ, the face, the structures of the face. So those are happening concurrently, and we have a team of 6 surgeons.
Wow.
5 plastic surgeons and 1 ophthalmologist who's specializes in oculoplastics to help us manage
So
the
an eye
eyelids and
doctor,
things.
yeah.
An eye doctor. And so we have the team split up into 3 in each room, and or 2 in each room, and the ophthalmologist and I are circulating between both rooms, and she's working on the eyelids, and I'm sort of controlling the pace of the operation and involved in many of the steps. So the procedure flows very well. We were in the cadaver lab rehearsing and
Practicing,
learning and practicing this procedure for 50 Saturdays over the last 3.5 years.
No kidding. Well, you were prepared.
50 full Saturdays. When the procedure was about to happen, none of us were nervous. None of us felt uncomfortable. Every member of the team, including the nurses and everybody else, knew exactly what they were supposed to do. They were comfortable in their role. Nobody felt that there was something that's going to come up that's going to be a surprise. So we went into this procedure with those 2 rooms going, 1 preparing and 1 procuring. And then once we took the organ, then we were all together working on the reconstruction of our patient, the recipient. And at that point, I had gotten advice from other surgeons who had done this multiple times to have forced breaks, because everybody's very excited during the initial parts of the procedure, and by the end of it, when you need the most delicate parts to be done, everybody's exhausted. So we started having, once we got to the part where we were reconstructing and we had 6 surgeons, then we started having forced breaks.
The family of the donor, it's one thing to donate, again, a kidney or a liver, but when part of what you're asking is for the part that looks like their loved one that they've just lost, is that a different discussion for the donor's family?
Of course, when someone signs their donor card or designates themselves as a donor on a driver's license, at this time we cannot ever presume that they understood that they're going to be donating a face or an upper extremity. So for face transplantation, it's a separate consent process. Okay. The organ procurement organization, which handles all organ allocation for deceased donors in our area, had a strict protocol of when to approach families for this gift.
Sure.
And it's only if the family gives explicit permission that they would consider their loved one as a potential face donor, then they would proceed with any further steps.
Does the patient bear a resemblance now to the donor?
Because of the complexity of the surgery that's done and the different bone structures, essentially the outcome is really a composite between both.
All right. You know, what an amazing story. And thank you both for sharing it with us. You know, 50 Saturdays in the cadaver lab doesn't sound like much fun to me, but congratulations for doing it. Thanks for all of your great work, and both of you, Dr. Samir Mardini and Dr. Hatem Amer, the first facial transplant at the Mayo Clinic. Thanks so much for being with us.
Thank you very much. It's a true pleasure and an honor.